Dr. Ashok Tuteja. Anyway, he's a professor of medicine in the Division of Gastroenterology at the University of Utah, and I'm happy to be working with him on a research study for the first time. It's exciting. His major area of research interest is lower intestinal function bowel disorders. He's been studying the role of infection in causing irritable bowel in Gulf War veterans for now almost 20 years. His work has demonstrated that gastroenteritis during travel and deployment is a risk factor for irritable bowel syndrome. He has completed 4 investigator-initiated clinical trials on IBS, which is irritable bowel, evaluating the role of antibiotics, probiotics, and anti-inflammatory agents in the treatment of IBS among veterans. He has ongoing studies on the role of diet and prebiotics among veterans. He's also been on the External Advisory Committee for the DoD clinical trials of Gulf War illness and is a member of the Data Safety Monitoring Board for the NIH National Pelvic Floor Network. Thank you for being here. I'm really thrilled, Ashok, that you could give us this talk.
Thank you very much, Nancy, for this nice introduction. I think I'll start my talk that, I'll tell you a little bit about the gut health, then I'll talk a little bit about IBS, the irritable bowel syndrome, and talk about how common is IBS among Gulf War veterans, and some of the treatment strategies and how we move forward about its treatment. So I think that before I say that IBS is I just want to say it's a functional bowel disorder. We do not call it functional anymore. We call it as a brain-gut disorder. And how it is defined is that patients have recurrent abdominal pain at least 1 day a week for 3 months and 2 or more. Either that pain improves when you have a bowel movement, or the pain is associated with change in frequency. Some people have more frequent bowel movements, and some people have less frequent bowel movement. And then there is a change in stool consistency. Some people have harder stools, and some people have looser stool along with the pain. That will be like IBS with constipation or IBS with diarrhea, depending on if it's harder stool or a looser stools. And this should not be explained by any biochemical or anatomical disorder. That these people have these symptoms and we cannot find a cause for these symptoms. That makes it a IBS. So how I started my work was that there was a study. It came in New England Journal in 1991, which showed that about 60% of the troops have diarrhea within 2 months of arriving. And a bacterial pathogen was identified only in 50% of the patient, E. coli was that. So that means most of the veterans who travel abroad will get a gastroenteritis. And later on, we found another study from Boston. They found that in these Gulf War veterans who were coming back, they had a lot of this abdominal pain relieved with bowel movement, that's like IBS criteria, loose stools, incomplete evacuation. These are the symptoms of IBS. So I thought that there should be a relationship with the gastroenteritis and these symptoms. So with that in mind, we proposed a study to look at the prevalence of bowel disorders before, during, and after deployment, and look at how common is IBS in these veterans, and how is IBS affecting their quality of life, and how is it associated with other factors. We also hypothesize that this IBS symptoms may be because of small bowel bacterial overgrowth, and that rifaximin, which is an antibiotic, will improve their symptoms. If you look at it, there's a lot of bacteria in the whole GI system, the ileum, the distal ileum, colon. So this is full of trillions of bacteria in the GI system. And maybe that flora changes. There's a bacterial overgrowth, and an antibiotic will help. So let's see what we found. We looked at the functional bowel disorders. These are the disorders or the brain gut disorders now, IBS or dyspepsia, which is like upper abdominal pain. They have constipation, they have diarrhea, nausea, vomiting, bloating, all these GI symptoms. We put them together before deployment. Look at that. Very, very low prevalence. During deployment, it rises almost 50%, like they said. And then even after deployment, our study, we found that after deployment, it still keeps increasing. Like I think even how the Leah Steele said that the prevalence keeps rising as even after deployment. So this is what we found, that the prevalence is higher during deployment and it persists even after they come back. This was about 10 to 15 years after deployment, their high prevalence. This is not our study. This was another study from Wisconsin. They looked at a small cohort and they found, you look at it, that there is a prevalence is GI symptoms. If you have Gulf illness, your prevalence is about 64%, and overall there is a 38%. Whereas in the normal public, it's about 10 to 15%. So the Gulf War veterans have a very high prevalence of GI symptoms, and they have high prevalence of IBS and other functional body disorder. It is not only our study, but other people have also shown that. And as we expected, those who had gastroenteritis during deployment, they were more likely to have all these symptoms. IBS, more common. Dyspepsia, functional bloating, constipation, functional diarrhea, they all are more common among those who had gastroenteritis among those who did not have gastroenteritis. And in our setup, about 44 to 45% of the people had gastroenteritis during deployment. And then, as we expected, their quality of life was lower in IBS, non-IBS, dyspepsia, no IBS. All these quality of life, relationships, sexual function, social function, food intolerance, health worry, body image, all these parameters of quality of life, it is more severe in people who have the disorder, IBS or functional diarrhea, all these, than those who do not have it. Similarly, we found that these people are also more likely to have anxiety, depression, and somatization. Then we wanted to see whether the breath test, like the bacterial overgrowth, is present in these IBS patients or not on the Gulf War veteran patient. We did a hydrogen breath test in these patients. If you look at it, the IBS patients had a 76% have a positive breath test compared to 57. So I think what we found was we found that the breath test is not a good test to study the gut microbiome to bacterial overgrowth. You see, the sensitivity and specificity was very low. That's even not only us, we others have also found the same thing. And then we looked at the effect of antibiotic. If you look at it, stool frequency, stool consistency, there may be some, there is not a single thing which is not crossing the middle line. The confidence interval. So in some ways, we found that rifaximin does not improve the symptoms. Antibiotics do not help these patients with the IBS and Gulf War veterans. There are studies similar which have shown positive as well as inconclusive or negative remarks, as we have shown. If you looked at the quality of life with antibiotic, some of them are positive, but none of them is not crossing the line. So overall, the confidence interval is on the both sides, whether the rifaximin or the placebo. So I think we were not able to show that it's definitely a good treatment for IBS in Gulf War veterans. So then we looked at the effect of probiotics. We looked at about 62 randomized subjects. We analyzed 53. We looked at their baseline psychological scores. And then we found that there was no change in the symptoms of Gulf War illness, including IBS, with probiotics. We used the VSL3 probiotic, which has 8 microbiome stromes, and we also looked at the quality of life for these Gulf War veterans. If you look at the quality of life, again, some changes, but some not. So so that this is we could not find a definitive positive relationship between the effect of probiotics on IBS or the Gulf War illness. I think this is consistent with the other literature also. Then we analyze these veterans with cytokine. Look at their cytokines before and after treatment with the one was there was no difference in the cytokine levels in IBS patients and the healthy control. And then similarly, we did not find the change, anything after probiotic. If you look at it, this is a pre and a post slide. Blue is pre, then is post, pre, post. There's no statistical difference in the cytokines before and after treatment with the probiotics. Then you looked at the gut microbiome also. Dr. Chatterjee was very kind to do the analysis for us. This is the placebo people, and this is the active, those who received the probiotics. Look at the placebo active, no change in probiotics before and after treatment. P-value does not change over there. If you looked at the individual bacteria, did they change or not? None of them significant in this. So actually, what if you look at the family level, genus level, we do not find none of these lactobacillus and all other different bacterial flora. We do not find any change significant with the probiotics. So what did we find? There was no change in the symptoms of gulf or illness, including IBS with probiotics, with the one which we use as VSL3. And there was no change in quality of life. There was no change in cytokines or the microbiota. That does not mean, I would like to emphasize, that does not mean that the probiotics are not good. You see, it may be that we studied the gut microbiome. There may be viruses, the fungi, which may be causing the symptom. Or it may be, you see, we treated them for only like a 8 weeks trial. That probiotics is not like an antibiotic for an infection or something. So maybe we should have treated them, like maybe need a trial which is long lasting, then we may have seen a response. Or maybe we did not have enough, the dose or the bacteria which we used, but not the correct bacteria which we need to use. I think this study should not discourage us to study probiotics. This should encourage us to study probiotics as to why we did not find the response and what did we make up for what we need to do. We need to study the gut microbiome more to understand what we need and what we do not need. This is as we know, this is a study from Wisconsin. They found that the gut microbiome in the Gulf for illness is different than the Gulf normal healthy veteran. So there is no doubt that the Gulf for flora is different. But can we make a change or not? That still remains open to the, that still we need to continue to study that. I think I'll just like to highlight also, one of the reasons maybe that IBS is a brain gut disorder. It's a brain as well as the gut. The change in the gut microbiota, diet, infection, inflammation will send a message to the brain. And then the brain will control the gut function by autonomic endocrine functions or entering nervous system. So there is a loop, brain-gut cycle. This is a brain-gut disorder, IBS. And so there may be alteration in the gut, or there may be alteration in the brain, or there may be alteration in the circuit, like I'm saying, autonomic or endocrine function, which are leading to dysfunction. And this is also applicable in the IBS. When we did our study, we looked at the other symptoms in these Gulf War veterans too. We looked at those other symptoms: headache, backache, asthma, trouble breathing, insomnia, fatigue, general symptoms. So all these other symptoms of unknown origin, we find that the people who had IBS in the Gulf War veterans who had IBS, they were more likely to have headaches, more likely to have insomnia, more likely to have fatigue, more likely to have general stiffness, joint pains, feeling of anxious, afraid, hot or cold spleen. They have an autonomic dysfunction, more in IBS patient than in that. So it tells us that the IBS or Gulf War illness, you could say in general, is a systemic disease. It's not, I'm not going to fix this disease by just fixing my one organ, or one treatment is not going to fix the disease. We need to have a, this, maybe the Q10, what they are doing, that because it fixes the whole system. Those kind of treatments are more likely to work, I think, in my study, in my observation, what it is, which our research shows, is more likely to help people than just a targeted treatment. I think this is, in conclusion, I'll say that it's a multi-system disorder of unknown etiology, and it's a brain gut disorder. And the typical standard focal, like shotgun treatment is not going to work in these patients. Thank you.